back to another episode of Scanning the Market. Today I'm joined with Thomas, the CPO and COO of TheraPixel. He is one of the few people who has been building AI in medical imaging for a decade. We go through his experience, the difference between the market then and the market now, what the future of radiology will look like, some of the hard learns that he's had to take, and of course the difference between selling in Europe and the US. I hope you enjoy. You've seen a lot of change. You've been in AI, for 10 years now?
Yeah.
Yeah, and I guess you've taken a European product and broken into the US, which, not many companies have really done successfully. So I guess, before we get into that sort of US expansion, I'm pretty interested to know what was like the original vision for TheraPixel when you joined.
Yeah. So that's an interesting question because from the very beginning, we were focusing on targeting the US market.
Okay,
So we've always have in mind to come to the US. We we indeed designed the product from both US and French feedback
sure,
initially. So it was already kind of made for the US, but when we first released the product, we
yeah,
realized that we were kind of missing things because we already had some preliminary sites, I would say, more in France,
sure,
but not much in the US. And so then we realized that we need to change a bit the way we integrate. So we still had to do some I would say customization or market fit for the US to have a different kind of product. So the engine was the same, most of the features were the same, but it was mainly in terms of integration. We really had to come up with this widget idea
sure.
um, to provide the information at a glance. And like one of the big difference I was very interesting to me is like the number of clicks people are able to make in the US was like way fewer than
Yeah,
in France. So we
yeah.
wanted extremely integrated and like no to not lose any time with integration, which was a big difference.
Everything just moves slower in Europe, right? It's so funny when we're recruiting for European countries in the US.
Yes.
We just tell them about the vacation time. Like everyone is off in Europe in August, like no one works. It's I know it's stereotypical, but it's the Americans aren't quite used to that sort of slower
Yeah, totally.
European culture, I suppose. Cool. All right. Well, it's interesting that you thought about it. You thought about the US to begin with. Yeah, not many people were in AI 10 years ago. What did the market, what did AI look like then? Compared to what it looks like now, because there's been so much development. It's insane.
Yeah, 10 years ago, uh, when uh, when we started the product, it was funny because obviously we all started with this kind of models at a study level. So it was just saying, is the cancer? No. And my first question as a product guy was like, but where it is? And
Yeah,
the AI team say, we can't say it right now. It's just like yes or no. So it's been a long way to from the overall prediction to actually detect the lesion, characterize the lesion, and to tell the radiologist this is where the AI seems to have flagged something. So that was like, yeah, from some algorithms, 2D only. That was also
sure.
the very first thing we've done. With a first FDA clearance on 2D as well in 2019. And same, I think we quickly realized that in the US, no one wanted an AI for 2D only.
Yeah,
Uh, they have all transitioned to tomosynthesis, which is the 3D of mammography, and that they wanted an AI for tomosynthesis. So we quickly had to develop a kind of, obviously it was based on the same kind of technologies, but we still had to train some models that were like made for 3D. That was
sure.
big shift, right? Because from a
Yeah.
2D image, which is a few megabytes, to a tomo, which is terabytes,
Yeah.
that's very different, very very different. So the models were the, the number of resources we needed was very different. So with all the accelerations of the different models for NVIDIA cards and all that,
Yeah.
it allowed us to train models on way bigger exams.
Yeah. I mean, that's what I was just thinking is in order to run the software, you have to have the hardware first, right? And I was just wondering if, yeah, we have obviously all the NVIDIA, yeah, you got the GPUs, the CPUs, all of the hardware nowadays. But, 8, 9, 10 years ago, I wonder if
Yeah.
it was just the hardware that was limiting the software development, or people just didn't understand that this sort of software was available, which I think created a lot of misconceptions. I mean, I hadn't heard of AI 10 years ago, really. I mean, when you heard of AI, you thought of like war, right? Or like like cyber attacks. I guess what were those misconceptions that you originally had to deal with, back then?
I, so to your answer on the hardware, I think as it was one limitations, but there were obviously more. Right? The accessing the data was pretty hard.
Yeah,
Um, and as you say, as a French company, it was there were not such available 3D images like tomosynthesis images in France. So we also had collecting some US data, but back then we were also like so focusing on 2D. So I think that was
yeah,
one of the misconceptions we had was like, oh yeah, mm, it will be usable anyway and people will like it. But like when you put that on the market and directly people tell you, we really need to do because in interviews people will we did market study obviously and people will
yeah,
always say yeah that would be useful but once they use it no we need Metomo. Okay. It's starting. And so yeah, getting the data was not that easy back in the days because first there were less. Tomo has still been introduced in the early 20s, but again in France there were not so many tomosynthesis available, so we had to work with some US sites. Hardware definitely, as you say, has evolved very quickly as well, so it was way harder to train models on the type of graphic cards that were available. We invested in graphic cards directly. We haven't used like the services, but Amazon or Google, whatever, would provide to train. We still think it was a good choice because in the end, the price to buy them, if you plan to use it for several years,
yeah,
it would cost less. But yeah, we had to reinvest every other year or so to get new graphic cards so that they would have better capacity. And we still do that because there's still
yeah.
new graphic cards for these foundation models and all of that are even more powerful, but we need to continue innovating.
Yeah, I mean, the price of graphic card. I think it's more. I know this is relevant, but it's more tied to like what crypto and things now. Since that sort of boomed, the price of graphic cards of even getting hold of them have been proving difficult.
Yeah.
'Cause there's such a high demand. So
Yeah.
you mentioned that like in junior market research, radiologists would say, yeah, this is great. But then actually like following through with it is a different thing. What was the first thing or first time that you sort of showed them something and you could actually see them say like, this is actually real now. We actually want to integrate this.
So that was, I think in France it's been easier with the first product we did. So again, only 2D. We still saw quite a lot of interest, and again, mainly because the adoption of 3D was slower and not in every single site or in very specific situations, like for diagnostic only and things like that. So this is where we people were really keen to use it and liked it. I would say almost from the beginning, you always have skepticals and people that would say, "Oh, his performances are not that great." Um, but yeah, I think that was I would say we started about the development in 2016, and I think in 2019 this is where we got the first like people using it and say this is valuable, and we got our first clients again in France first by that time.
Yeah,
And in the US, we released our first 3D algorithm that started to get some tractions. So this is why it became, I would say, more interesting for the US radiologists. And this was in 2021. So we launched in 2021. So
sure.
we started to get a bit of traction, but the big shift was really so I would say yeah, last RSNA, a little bit before, but when we really oh yeah, no, let me take that back a little bit. So it was probably a little bit before. So again, we had this 3D algorithm, but not as integrated as it is
Yeah,
right now. And for the US, it was so important. So this is why we developed a widget. And so then a year after, this is where people really started to get it. Like, oh yeah, I love that because I get this feedback right when I open my case. It puts me in a state of mind where I know what to do. Like if it's a red, I would be very cautious. If it's a green, I'll kind of be a little bit reassured. And
yeah.
yellow, I have to think without if I would not have an AI. So yeah, this would be more like 2021. And then again, a big shift in 2020 three when we kind of started to launch our new suite with that helped with the entire screening workflow. And that was, I think it's about when I moved to the US a little bit before that, where we say, okay, what can we do more to to really tailor the product for the US? And we've done quite a lot of extensive market research, and the main thing was to cover most of things that automatic tasks that a radiologist would do during his workflow and go further than just detection of cancer, but really try to cover the entire workflow
Yeah.
from worklist organization to density to, of course, cancer detection, and to reporting. And that was the big piece we released at last RSNA as the capability of create a sort of draft report. And that was again a big shift where people say, "Oh yeah, that's really nice."
One of the products I saw um, that I found super interesting, I know this is really basic, was, and obviously correct me if I'm wrong, but you'd go into the hospital a couple of weeks prior and you'd record and see how efficient they were without AI, and
Mm.
then would then compare that to what they could achieve with TheraPixel, and you could show them in plain numbers, like this is the exact improvement that we can provide you in your hospital, not other case studies, but this is your hospital. This is what we can do. That I found super interesting. That sounds just like such common sense to me. And I don't know how common practice that actually is.
Yeah, yeah, it's a good point. We thought about that very early, and I think this is was also part of the widget strategy. It's because of that we can actually measure the reading time between the opening of two cases, and so that we can actually prove that the saving time with the
Yeah.
AI. So we kind of run, as you say, we run a baseline. So we would like install the widget in the background,
Hmm.
uh, and for a month or so, and then we start the AI, and then we can show them, oh look, you've actually it helps you to read faster, and then we can build a compelling case for purchase. And that was another thing that we've done uniquely, because if you only do integration within the DICOM viewer, you have no control of the workflow,
Sure.
right? It's provided DICOM SC, DICOM SR, and it's static, it's in the viewer, but then you cannot get all this data. Yeah, that's something we've done again, very tailored to the US market, because in France, and as a no interesting things about what you raised initially is like, what are the key difference in France? Most of the patients, all patients, they get a clinical exam
Yeah.
in addition to a mammography and potentially an ultrasound. So the time spent by the radiologist on reading the mammo is actually like little compared to
Sure.
the entire time with the patients, like 15-minute exams where there's all the clinical examination, potential ultrasound. So s- improving the speed of reading a mammography was not a bottleneck at all, right? Because it was taking like 1 to 2 minutes out of 15. It doesn't bring value to be faster. However, in the US, like this was a big thing, right? And it was
Yeah.
like, okay, how can we prove that we can be faster? And it goes back to your question, and we answered with a widget to show that indeed, with the green, they feel reassured, they can read faster, so that then there is a compelling case for purchase because everything. Unfortunately, it's difficult to pay for quality, so it has to be for efficiency, and that was the big play we took in the US.
Yeah. I talking about efficiency, I did an episode with Airs Medical, and they were Gina was who was their chief strategy officer was talking about if your product doesn't have like a clear ROI, then it's most likely not going to succeed in the US, right? And as much as you can improve quality, if you can't get more patients through the door ultimately and more scans read quickly, the people who control the purse strings probably aren't going to want to pay for it, right? If it's just a clearer image or better detection, it has to
Yeah.
do everything.
Yeah, unfortunately, we haven't reached that point yet where there is a reimbursement, because usually this is where reimbursement would come in the loop.
Hmm.
Uh, because you find cancer earlier, you can reduce the cost of treatment, and then there's a path for reimbursement, and then of
Hmm.
course the quality overall. But from a center which the main issue is somehow is to be profitable, right? And be able
Yep.
to continue to invest money, recruit more people, more machines, and all of that. They want to be profitable as any company.
Hmm.
And so paying for quality is important, but to a certain extent, right? And
Yep.
there's not a super strong business case and you can avoid a few liability things, of course, but it's super difficult to build a business case around that because you don't know how many you're gonna get. You never know how many they're gonna cost you. So
Yep.
it's and you already pay insurance for that. So it's super difficult to only build a case for quality. So indeed, this is where the getting more patient in the door, as you say, is more compelling. You still need, of course, to have the infrastructure for that. Do you have enough technologies? Do you have enough machines? Do you have enough radiologists as well?
Yep.
Sometimes, of course, we help to reduce the time, but if you really want to improve everything, you also need all of these elements. So it's still a sweet spot where you need to be able to do more. You're missing some radiologists, and then Mamoscreen can help you
Yep.
to faster, and then there's a case for purchase.
You mentioned a little bit earlier about the sort of differences between, yeah, I guess France or Europe and the US. Obviously I moved here nearly 2 years ago, and I can see the differences. I'd be interested to know what you think, like culturally, the difference is selling into the US as opposed to Europe.
But it's definitely a lot of differences. I think I would say that first is the size of institutions makes
Yep.
it extremely different. Um, in France, it would be more like, I would say, about 10 radiologists in the practice. In the US, a mid-size would be considered like more like 60 to 80 radiologists.
Hmm.
So the decisions are definitely different. In France, it would be more a radiologist. So again, mid-size would be 10 radiologists. They usually have a board, can be 5, 6 people, whatever. So you need to convince these 6 people. Um, there are some challenges to that because they not all do mammo. So sometimes a partner would not want to invest in mammo because it doesn't really care.
Yep.
Uh, but usually it's I would say in a sense it can be an easier sell because you have less stakeholders to
Yep.
convince. But obviously the opportunity are much smaller because when we have a business model based on the number of exams, and so
Hmm.
ultimately these sites are smaller than opportunity in the US. And in the US, the uh, as there are way bigger practices, it is usually a little bit more organized in terms of sales. So first, you always have some IT people, which is not the case in France, but it goes back to a point of why it's super well integrated in the US and it works extremely smoothly because they have the capability to build this team with such big
Sure.
practices. They have IT teams, and so we have CIO, COO, and so then you need to convince, I would say, stakeholders not only at the clinical level,
Yeah.
but at the IT level and operational level, and of course financial level,
Yeah.
and which is in France would be more, I would say, just clinical. When you know that you have a champion, it's way easier to sell in France rather than in the US. You need a champion, but you also need to convince all of the stakeholders. So that's one thing. The other thing, I think the very good thing in the US and that I love is the pragmatism of
Yeah.
the US people. So when they see the value, they will
Yeah.
make it happen.
Yes, that's true.
It's yes or no. And like in France, we yeah maybe, and we speak and like we have a lot of relationships around the sales, but sometimes things will not happen. In the US, if it does happen, people will not answer you.
Yeah.
But if they start to answer you, there's attraction and they want to move forward. And this is extremely pragmatic. You're going to get, again, the IT team, you're going to discuss IT, you're going to get the operational team, you're going to discuss operations, and then you're going to get clinical, and you're going to speak clinical. And people are very like dedicated roles, and they tend to not question too much on the other kind of spectrum of the different teams, and that is extremely appreciable.
What I find most interesting is, and obviously, you're out, you've been out selling, right? And you're talking to all these people, and you've got a sales team. The biggest difference I see between successful salespeople, and this is just in AI, I suppose, or radiology software, as opposed to devices, um, is the best people are not your traditional salespeople. I almost think of them as like project managers because they're coming in and they're managing so many different pieces. A pack system could take 2 years to sell, right? An AI system, what, 3, 6 months sometimes, maybe longer, right? You've got to manage, as you said, IT, finance, cyber, the actual radiologists. You've got to be able to coordinate internally your customer success team, your project management team, your finance team, right? Your implementation team. Um, there's so many moving pieces that I think in Europe, perhaps, at least from my experience, there wasn't. You'd get a traditional, like hunter salesperson in Europe, and they'd go out and sell. Whereas here, you have to be able to open doors, but then you have to be able to, I think, slow down a little bit um, and manage the large hospitals. Which brings me to my next question: is the bigger the hospital, the more politics are involved, right? And the more people you have to make happy, and this person could be in this company's pocket, right? Or they could be someone else using someone else's. So I guess how do you balance, I guess, model accuracy and building a great product with, I guess, hospital politics, but also like the realities of workflow, right? Some radiologists just won't want to change what they're doing, or they just don't buy into what you're trying to sell.
Yeah, it's good and not an easy question. And yeah, I can agree more on the sales people. Is as you say, is a lot of project management in a
Hmm.
sense, where you really need to align all the different stakeholders. And I think what we've seen that is very important for a sell to go all the way is to have also a team within the system that can talk between each other.
Yeah.
Mm. And this has been the most successful in actually the more like mid-sized practices because in big house system, as you say, there's usually it's very there's big silos and
Yeah.
that they do not speak to each other. So it can be really hard um, to get a tractions because a clinical team will barely speak with the IT and vice versa and to operations, and so it's very difficult to get things moving on these deals because we miss this kind of coordination, and sometimes a good sell indeed this is what they will be able to do, create
Yeah.
this. um, group of thinking, and then
Like
getting
cohesion.
equation totally. And then, yeah, two questions. So if I understand well, it's like how do we kind of have a product that fits for a super large institution and a mid-sized practice in terms of, yeah, from calibration to integration to a lot of things. It's a very difficult question. Um, as an example, I would say that usually it's still like question me on how a more like academic institution would have more templated feedback when in a private institution we have feedback. People say, I can't read without your
Hmm.
system. It's I'm just loving it so much, and it helped me to be way faster and save time. Whether I think in academic they probably have more time, that's how I would explain it. And they don't especially see the value of the speed, and then it's a little bit more on quality than
Hmm.
speed, and where they will question everything of
Yeah.
the results. And of course, this is not perfect technology. No one has a perfect system. There are some false positive, there are some false negative. And we've all never pretended that we are perfect, but still they will have a tendency to question other things. Well,
Yeah.
a good thing, they're still using it, so I think they still like it in a sense. But like sometimes this is very very contrasted. And so then we could ask questions like, should we do a specific product for a university, where academic institutions where maybe the sensitivity is higher, and to the cost of, indeed, there would be less negative case, but we would miss less. Um, but then it's difficult, right? Because you cannot have clinical data on product that are calibrated differently.
Yeah.
If you have different calibration, then if you do a study in an academic institution, it will not be valid in another type of centers, which is the majority of our users now. It's more on the kind of, I would say, private
Yeah.
radiology practices rather than in academic. So and these private institutions, they don't have the time to do the studies neither. So it's a difficult question. So I think it's this, part of the answer is the score that we've built with different categories. It allows a little bit, depending on where you work,
Yeah.
to behave a bit differently. Like a private site will usually trace the green, trace the red, not look at yellows. And academic
Right.
will look a little bit more at yellows, and yeah, maybe. Yeah. So it's just partly of the answer. And I think that the other big point is integration. Usually these private practice are easier to integrate with, because the systems are a little bit easier. The team usually are a little bit more competent, I would say.
Hmm.
Um, Not always, of course, but like some of these like mid-size top notch have teams that are extremely tech savvy, and
Yes.
they they help you a lot to integrate. Like sometimes you
Yeah.
don't even have to do the work, rather than in some institutions you have to do everything. And they have older versions of some systems, so it
It's
gives us
difficult.
more challenges.
Yeah.
Oh, we're supported only from this version. Oh yeah, but an upgrade would take 6 months. I'm like, okay, so maybe we'll try to support the older version. So sometimes we have to for this we have to adapt a little bit to make things work.
Yeah. I guess you're talking about adaptability and um, changes. I think that comes with scaling, right? I'd be interested to know, when you really started to grow, what was the first thing that broke, and like how did you sort of overcome that?
Yeah, I guess this is trying to think. Obviously our capability to do these quick changes. I was speaking about, like, oh yeah, we're gonna maybe do a quick fix to help with integrating with this system because we have an older version of a viewer, whatever. This has become way more challenging
Sure.
right now. because with many sites and many integrations that we support, we need to standardize a little bit things. And as a chief of product, the one thing, excuse me, was the to plan way more in advance releases. So
Sure.
before we were doing releases every other weeks, every month, whatever. Now it's more like, okay, we need to plan a release a few months in advance. We need to gather all the different feedbacks we have from the different sites, and we need to prioritize them way more. And then we need kind of to fix what has been planned for this release and not constantly modify
Yeah.
on a weekly basis the requirements. Whether than in the past, it was much easier with a smaller team, less clients, but we could like break everything,
Yeah.
change the priorities. Even like I would say in production, like now we cannot break the system because we would have too many clients that would be disappointed. Before we had, oh yeah, we should do a quick fix on the AI. We had like modifying the AI. It was we knew we had just a few sites and at a certain time and at night we were no one using it, and that we would be able to fix it in the morning in France. So it was these things were possible. Now we can't do that
Yeah.
anymore because we have too many sites relying on the technology. So we really need to have staging environment, even with our clients, where we're going to test first the release, we're going to accept the release, and then put it in production. So the cycles from product conception to actually using by the system or site is are much smaller because there's so many
Yeah.
steps, and we have to make sure that and as you say, we broke things doing that, and then we realized, oh, maybe we should structure a little bit
Yeah.
more to avoid this kind of issues.
It's so funny that you mentioned that. Literally last week, I started working with a new client who are literally a year old, right? They've got 15, 20 people.
Hmm.
And they said, right, we want these people who can keep up with our updates, right? Because we're releasing new updates pretty much every day. Multiple a week. And from a recruiter standpoint, the the roles that people always ask us to work first is, yeah, except for like when they're building the product for like engineers, it's almost commercial like leadership, right? Or the first like implementation person. Um, but I think maybe there'd be a lot more value in hiring a really experienced product person who knows how to slow down the product development and put those processes in place. Because I mean, I work with other companies who do the same, and they have so many changes that they actually just can't keep up with what they're doing, and so many things are being broken. And so I think there's probably, I know you learned as you went along, but I wonder if companies can avoid that just by bringing in someone like you who have already learned that. I just don't see it that often.
Yeah, a little bit um, aligned with that is I think our CEO, um, when he joined the company in 2019, so we already had some algorithm, um,
Hmm.
like the initial discussions in for Mamo 2D, and the first thing he realized that there is no product team,
Yeah.
and he said that we need to structure a product team, and this is why he identified me to go as product. I was doing some data partnerships, and already I was doing some sort of product, but not officially. And they say
Yeah.
we need to restructure a team. And I think that was an extremely good idea because indeed you need a department, and I think a lot of young company, for some reason, the CEO or the CTO, whatever, they do product, they think they can do product, but you really need someone which is doing that all the time. And as you
Yeah.
say, structuring priorities, releases, getting the feedback, organizing the feedback, and obviously when you have like one client, you don't have ton of feedback, so you don't need
Yeah.
that. But being prepared for that, and I guess yes, having someone that can structure that, and also what has worked for us. I don't know if every single product person would be willing to do so, but for this complex, and I guess probably for this complex deal where, as you say, a sales can sometimes do it, but it's extremely rare, but can really understand from clinical to IT
Yeah.
uh, and to operations, and can bridge these different things together. This is really important, and that's where I think I helped with a lot of modesty, but like I helped a lot, like on this deal. Oh yeah, we can make that happen
Yeah.
by doing that, and then
Hmm.
internally reflecting back the need, getting the team, dev team, AI team able to do it, and then having something that works in production. And
Yeah.
that's a key thing for, I guess, the development and the adoption, right? Because
Yeah.
people want, so that it can be usable and more than usable, valuable.
Yeah. It's interesting. It sort of links on sort of nicely to what I was wanting to talk about in the current market. You said a good product person can come in and say, right, yeah, we can make this happen. I feel like perhaps there's not enough product people coming in and saying, no, we can't make this happen. But what you're asking for isn't realistic. Um, both to, I think this works both ways, both to the hospital, but also internally to your investors, to your CEO, to your salespeople, whoever it is. VCs are coming in and they're giving $50 million, right? And expecting a return in a year, 2 years. And you and I both know you can't sell that quickly, right? You took investment on early and you've not got any more, and it's taking you time to get up to where you are now, right? Um, how do you sort of see, the next 5 years? Because we spoke about foundation stuff before we started recording a little bit, and we've spoken about it previously, but do you see the next 5 years being like in automation? That's where the real value is going to come, or could it be augmentation? Or do you think like there's going to be a full workflow redesign?
Yeah, I'm I'm still puzzled or impressed by this money continuing to flow in AI
Me
for
too.
radiology
Me
with
too.
so many so many actors already, and so few business cases that have been proven yet, and company that have succeeded. So yeah, it's I agree with you. It's very interesting, and yeah, we, to your point, getting something in 2 years in, it's impossible, and nothing's going to change with foundation models. I think there's definitely a buzz and or a trend or whatever, thinking that it's going to, oh yeah, that's going to solve all the issues that the previous AI generation has solved. I
Yeah.
don't think so. Um, Not at all. The things, obviously it will help with, as we discussed initially, but it was true 10 years ago. Train model faster,
Yeah.
um, models that are able to do more things. So it will help to do what we tried to do with this current model, like to do more things within the workflow. So now we have a model that does cancer detection,
Hmm.
density, image quality, and indeed tomorrow we can hope that this foundation model will do the three things with
Yeah.
one unique model. But it doesn't mean it's going to drastically change anything. Like, so first we have to prove that model-wise it will be more, it would have better performances. For now, I don't think anyone has proved anything yet. There actually, I think it was a paper from Glimmer that actually, and I think it was nice from them to show to the world that this is actually the case. For now, they have not been able to overperform this basic CNN with foundation models. It might
Interesting.
happen. Not saying it's not going to happen, but this is currently where we are, and we're also working in foundation model, and we have the same kind of, I would not say issue, but it's the same limitations for now, where we have one algorithm able to do all the different tasks we do with different algorithms, but for now we have not been able to match yet the
Yeah.
performances of all single models that have been carefully trained and all of that. So it can accelerate a little bit some training. I think the real thing it's going to bring, it's, and to the paradigm changes 10 years ago, is that we were not even sure it would be any business case for the small, I would say, rare disease or of things that would be super costly to train with older
Sure.
CNN. But now with foundation model, we can be able to also provide this type of outputs with AI. So that's I think is the big shift here, is that it will help to access to some rarer disease or smaller things to AI technologies. So that's one thing. In terms of automation, this is more the agentic. So I think it's even another type of technology. Foundation model is one, and agentic is even another one. Is probably even further away, or very
Yep.
likely further away. And again, the promise to break everything and to have everything connected between each other. I love the promise.
Yeah.
I, I wish it would happen. But like as you say, changing a packs takes 2 years. So
Yeah.
this and I think and it's great that we have a startup promising that we're gonna be able to do everything, packs, viewer, all AI and all of that. The vision is extremely nice, but like in practice, the cost of changing these things and again it is you have patience behind that, right? You
Hmm.
cannot break the packs from a day to another. It has to be extremely reliable. And this PAX company, they have been existing for years, and so they have built robust cycles. They have built
Yeah.
this product more or less, but like of course they some could benefit to be a little bit more innovative and kind of change a bit things. So there is room to do better. Um, but to a point to have a general radiologist with a unique system, that's going to be a difficult. I think and to conclude on that, what we're going to see, it's more, and this is what we think at TheraPixel, and I truly believe it's more like some vertical approaches, and for us, it's easy, it's breast
Yeah.
um, um, imaging, and then it would help us to train MRI model, ultrasound model, and
Yeah.
maybe some also design some environments where we can kind of treat all the breast imaging in one place.
Sure.
That I can see, but like a one unique, that's probably way further down the line. But there will
Oh
be a
yeah.
lot of areas to that.
Oh yeah. Um, I mean, yeah. I mean, it's just so hard to make a prediction because things change so quickly, right? I can't remember life without ChatGPT. I like, and that was 2 or 3 years ago, right? Um, like it's yeah, what will happen next year or the year after? I mean, it's really hard for us to predict because we just don't know. You know, we're speaking about hardware. We don't know what hardware will come out that will allow you to be able to do that, right? Or what software what might come out. Um, yeah, it's interesting. I guess then
Yeah,
my final.
yeah, I guess in 10 years it's difficult. Yeah, but in
Yeah,
5 years, I think it's we can foresee what I was saying, more like models that are able to do a bit more things. Like for CT scans or X-rays, it's even easier than mammo, because mammo we only have cancer detection, right? I mean,
yeah,
in a mammography, you have BAC that is kind of emerging, but mainly we have cancer to detect. In a CT scan, you have thousands of things to detect, right? And this is where I
yeah,
think this foundation can really help. And we see use cases with Harrison AI Doc, whatever. They're doing like, they are able to detect way more things and create structured reporting based on all this, on these foundation models. And this is a clear it's pretty clear that this is going to happen and we're going to get first FDA clearances. But yeah, and actually there's to my point, and sorry, I'll let you use the question, but then there's the regulatory question, right? Like, how do we, because right now we have to clear all the different findings one by one, but it
yeah,
doesn't scale to these foundation models where you might have 100 findings tomorrow on a CT scan. So how do you clear that?
yeah,
It's a big unknown.
yeah. There's just a lot of unknowns,
Yeah.
which make it difficult. I guess then, sort of to wrap up, I know not to make you feel old. We keep talking about this 10 years in the space, but there's generally, my last guest was the CEO of River Rain, and he's been in the game for a long time, but I don't really know many people, because most people came from like Philips or GE doing, um, like capital equipment and then moved into software, or they were selling packs and then moved into AI. I guess this is a 2-in-1 question. What's the hardest lesson that you've learned from the last 10 years of building AI? And if you were to start TheraPixel today, what would you do differently?
I was not prepared to that one.
Like to keep
um,
you on your toes?
let me think. Well, I guess first this bikes or hardware company, they probably not too far one, but the obviously this is an extremely unique kind of product, right?
Hmm.
The way that you need data, this is a field that was not existing 10 years ago, data engineer. And so
Hmm.
collecting data, having your data team, structuring this, we spend like hours and thousands of dollars on just like getting data, structuring them, cleaning them. So this is a thing that obviously no one known.
Yeah.
So that's one thing. And following that, of course, there's all the deep learning, but which can be kind of related to basic R&D, I would say, because
Hmm.
usually it works as a dev team, but it's more like an AI team, but they do experiments. It's a bit longer, right? But yeah, maybe another lesson is obviously the release cycle for AI are way longer than a typical dev cycle because you need to do experiments, and then if it works, and these experiments take quite some time. The other things that is pretty unique to the field is the what we call like AI ops. So you have
Yeah.
the ops, and now we also have a team of AI ops. So how to put an algorithm in production?
Hmm.
Because they are trained on specific machine, they are testing a specific machine that we use for internal research. But then when we go to the cloud, and we have different GPUs, we have different environments, and of course we want it to be extremely reliable. So we've been a few years ago we've been facing some issues with some processing, but where for some reason some cases were not processed, and we didn't really know why. And so this is where we created the team where the ops would be able to bring the knowledge, the SRE engineers among the cloud, and would bring with the AI team together to discuss why is this case failing. And we increased drastically the number of cases that is now processing. We have more like 99.98% of cases that would process without any failure because we have created this kind of team. So that was kind of a unique thing to a field. And of course, all the regulatory aspect of it, right? It's you need some specific clinical proof. Um, some devices do need some clinical proof, so they're used to it. But I guess there's some specificity to it, the type of study, the retrospective data that you need. Again, you know that I'm sure you know there's a big trend, let's say from last year from the FDA to check if there's any bias in
Yeah.
race. These services very specific needs to a field. So what I will say, I would have to start differently 10 years ago. No, I guess not so much because it was just the way it was, right? We
Yeah.
started with again few people, so we couldn't have this AI
Yeah. Y-
devs kind of
You
things.
don't know what you don't know, right?
Yeah,
That's
yeah.
that's
Now, obviously, yeah, getting some. I think AI ops was a big things we did recently that really helped to improve its reliability. Of course, having a data team, but this we had it from the beginning because we were already
yeah.
an AI company, and we identified that data was very important.
Sure. All right. Well, look, I appreciate you taking your time. It's been good getting to. I mean, we've just never really sat and spoke about TheraPixel's journey, your journey. So it's interesting for me to learn. I think a lot of people will be interested because most people are still quite new to the space, like 3 or 4 years in the space, and so much has gone on that I don't think you can create enough perspective being in the space for that short. Myself included, right? I don't know what it was like, 10 years ago. So it's nice to see or hear from someone who has, I think, seen those changes. So I appreciate you taking your time and coming on.
Yeah, of course. Thanks, Jay. It was a pleasure to share a little bit of this long journey. So much
Yeah,
to to tell, and yeah, the as you say, the well, I'm excited about the future. There's still so much to do. There's still
yeah,
so many areas that are not explored yet, and yeah, these new technologies are fascinating. They cost way more, so
yeah.
that's also a thing. Going back to the investment point, the thing is, if you want to start a startup on foundation models, you need a ton of money.
Oh yeah,
Uh, but I don't think that's the answer for everything. I'm still thinking there are some areas where just a regular CNN could do a lot of good things, and you don't have especially to do every single things. But yeah, we'll see how the consolidation, because obviously you know that well. We've been seeing each other so many years at RSNA. The
yeah.
number of vendors is ridiculous. Like,
It's
how do
insane.
you navigate? Like, as a radiologist, how do you choose? How do you navigate? And obviously some consolidation will happen with packs, with manufacturers between AI and
Yeah,
maybe kind of foundational things. So yeah, so in the end, we'll foresee either more verticality and or some some more complete AI offering. We've seen like Brand Depot have kind of acquired so many AI right now, and they try to do that. So there's a lot of interesting things happening, and we'll see where we are
there
in
is.
five.
Let's see if we can try and keep up with it. Thank
Yeah.
Yeah, yeah, sure.
Well,
Well, yeah, thanks for taking your time.